Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. For today's episode, we're going to be taking a bit of a different approach. No guest today, just myself. And we're going to be going through a number of different topics that I've come across over the last few weeks in my day-to-day office practice here that I thought would be useful to share with you guys at home. Topics for various ages, various medical conditions, but things that have come up where I've thought, aha, that's one where I think that people would be interested in that kind of information. So it's going to be a whole bunch of different topics. There's really no semblance of organization here, no kind of thread that runs through these topics, but hopefully some useful tidbits that you'll take away from today. So we'll jump right into some summer topics, obviously in the middle of July here, that I've been seeing. So we've seen a few patients with tick bites. I'm not sure if any of you have come across this yet. Obviously, year by year, this seems to be getting worse in the region where people are having tick exposures. So just as a reminder, if you do find a tick on you, if you are confident that you've gotten the tick off within 24 hours, so that there's no possible way the thing was on you for more than 24 hours, the risk of transmission of Lyme disease is essentially zero and doesn't require any further follow-up. If you find a tick on you and it's a deer tick, and again, how to distinguish between deer and dog ticks we've talked about in previous episodes, but there's lots of good Google images that go through the difference between these. But if it's a deer tick and there's a possibility it's been on you for more than 24 hours, it is important at that point to be seen by a health professional right away to get on prophylactic antibiotics. Okay, you don't need to wait for that target lesion. If it's a tick exposure for possibly more than 24 hours, make sure you get seen by a doc. And I've already seen a patient with Lyme disease in the past week here in the office who did have a tick exposure, got them on treatment early, and those risks of long-term Lyme disease are not there if we get early treatment. So again, it's for deer ticks. If it's a dog tick, no concern. Other issues, obviously, every summer, sunscreen, please, SPF 50 or greater. Make sure you reapply sunscreen every couple of hours. Basically, the equivalent of a bit of a shot glass full of sunscreen should cover your body. It's also a good time of year since, obviously, you may be seeing people with less clothes on, either beach or elsewhere, to be checking for moles. If any new lesions pop up, don't be afraid to follow up with your family doctor. As you know, we do see melanomas pop up. We see non-melanoma skin cancers pop up. So good reminder, summertime, if you haven't taken a peek head to toe on yourself, or if you live alone and can't view, especially your back, don't hesitate to give your doctor a call to get a check, especially if you're older age, to make sure nothing's hiding in areas that you can't see yourself. Two more quick things for the summer. Obviously, exercise. This is the best time of year to be able to get outside. We all kind of brew winter where maybe we can't be as physically active as we can. So obviously a good reminder, July, August, September, these are going to be our best months to get outdoors, doing anything that you enjoy doing that gets the heart going, that is at a pace a bit quicker than you can carry on a conversation. So whether that's walking, jogging, swimming, cycling, rollerblading, anything you enjoy outside, and again, with others too, right? We know that socialization aspect is super important for keeping you going, for keeping you motivated. So if we haven't already, try that, and again, give it a few months of getting back in that good routine. Obviously, some of us fell out of that through winter and spring, so obviously a good reset. Alcohol consumption for some individuals does tend to go up in the summer. Please be cognizant of that. We know that alcohol obviously is a carcinogen. We know increases the risk of heart disease. Put your blood pressure up. I'm not saying not to consume at all, but we know it can be problematic use for some individuals come this time of year. So trying to moderate that, and weight as well. Just general nutrition. Using this to eat more, fruits, vegetables, things you can get fresh, and watching overall carb intake, not getting into the habit of eating out. Okay, so some overall summer things to kind of reset ourselves. Heading into the school year, two things I like to remind parents of for kids either going back to school or starting school, making sure that we're up to date on our eye exams. So every child who has yet to start school, before starting school, should get out to see the optometrist at least once for a baseline eye exam. What we do here in your family doctor's office, looking at the eyes, that is not sufficient to be examining eyes for reading and finding other issues that may be issues for kids. So making sure you are seeing the optometrist, and making sure you're following up with your dentist at whatever interval they've determined. So for kids, whether that's 3, 6, 9 months, whatever your dentist has deemed appropriate, good time to get that in place before the school year starts. One thing I've been seeing recently, so obviously more people outside, more people doing some yard work or puttering around their vehicles and cutting themselves and basic wound care. I think I've mentioned it before, but just as a reminder that there is virtually no reason to put hydrogen peroxide on any wound. I still see it. I'm going to probably rail on this topic every year for as long as I do this show. But there is no reason to put hydrogen peroxide on a wound. It interferes with wound healing. People will put polysporin on wounds right away as well. There's no reason for that. The best thing to do for a wound that you don't think requires further medical attention is going to be soap and water. Just simple kind of running it under the tap, maybe a little bit of soap, and then just leaving it alone. If you think that it does require medical attention, again, still soap, water, and seeing a doc. But this idea of hydrogen peroxide or self-treating polysporin for maybe it's an infection, we highly discourage that. Okay, so we'll see how the next year goes. Hopefully we have a hydrogen peroxide free year in the practice, but if not, we'll be reminding everyone again next year. A few things I've been seeing interestingly for patients who have been diagnosed in the past with iron deficiency or B12 deficiency or vitamin D deficiency. I took on a patient who had blood work done years ago by a different doctor and was found to be B12 deficient and no other testing that they were just put on B12 at the time. Saw that and thought, one of the causes, not everyone has this, but sometimes these deficiencies can be caused by celiac disease. And lo and behold, this patient actually had celiac disease that had been going on for years, but the patient didn't know. So if you've been ever diagnosed as having B12 deficiency, vitamin D deficiency, or iron deficiency, and you're not sure whether you've been tested for celiac, it's a decent thing to bring up at your next visit with your doc. You don't have to run out and call them this coming week, of course, but at some point, just asking them if you've been tested for celiac. Because again, with people going from doc to, I know there's been a lot of transition for people with their family docs over the last few years with retirements and that. So sometimes things may have been tested or not tested with the previous doc. So again, if you have either of those conditions and haven't been tested for celiac, again, good idea to bring that up with your current doc. Also, if you've had restless leg syndrome for any length of time, making sure that you ask your doc about an iron level. If you haven't been ever tested for that, it's one of the most common causes of restless leg syndrome is iron deficiency, and often when we diagnose that iron deficiency can lead to other tests as well. So not just kind of suffering with restless legs, asking for an iron test can be a good idea. One other quick test to be asking for is if you've been diagnosed with carpal tunnel syndrome, making sure that you've been tested for hypothyroidism. So that's an underactive thyroid. In some patients, not all and not necessarily commonly, but carpal tunnel syndrome can be caused by an underactive thyroid. So making sure that hasn't been overlooked in the past. We're going to take a quick break and we'll be right back after this message. Hi, welcome back. Again, today's episode, we're dealing with a whole host of different issues that I've been seeing in my day-to-day family practice with some little tidbits that I think some of you might find useful. So again, we've addressed some summertime issues already, some wound care issues, and some blood work that you can be asking about with your family doc. A couple of medication-related topics that I think might be interesting. Over the years, I know there's been conflicting kind of evidence and conflicting advice given around aspirin use, where some patients may be taking it because their doctor recommended it. Some patients may be on it because they heard about it from somebody, or some other specialist told them to take it and it's never been documented in their chart. Maybe I have it documented in your chart that I think you're on it, but since it's an over-the-counter medication and I don't prescribe it, maybe you've stopped using it a while ago. It's important. I think it's a useful thing to maybe jot down for the next time that you see your doctor for whatever reason, just to review those over-the-counter medications and especially aspirin use, just to make sure you're having a conversation with your doc about should you be on the aspirin, should you not be on the aspirin, because I think it's something that we've maybe taken a bit too casually over the years, generally, between patients and doctors around this. So again, just making a note, just to kind of formalize whether you should be on aspirin or not. For those with a history of heart disease or stroke, Again, specialists may have told them to be on aspirin, plus sometimes a different blood thinner as well. And the duration of that has changed over the years, where it used to be 12 months. Some patients, it extended to 30 months for being on aspirin and either Plavix or Brilinta. And then now there's some evidence that, well, maybe even a shorter course of aspirin with a longer course of Plavix might be useful. Bottom line is, if you have a history of heart attack or stroke, and you've been either prescribed or recommended to take aspirin plus maybe a different medication, again, checking in with your family doctor next time you see them, just to double check which one you should be on, has there been any change in evidence, and how long to be on these for. Okay, again, please don't make any changes to any of this stuff until you speak to your doctor. That's either starting something or stopping something. Absolutely critical to be talking to your doctor about this. We'll talk about stomach medication. So some people, some of you likely have been prescribed a medication called a proton pump inhibitor in the past. So this is a medication that decreases stomach acid. We use it to treat when patients have reflux, or if they have a history of gastritis or inflammation, or if they have ulcers. This is a class of medication that you'll see prescribed. One of the things that we like to review is that if you've been prescribed it in the past for a brief course, let's say you had maybe some reflux in the past that resolved itself, we know that because of inertia, because of just kind of prescribing habits, that some people may have been continued it for years and years without actually ever reassessing, did you actually need to continue this, or can it be stopped? Now, if you've been started it because of a previous upper gastric bleed or severe esophagitis, or you've been on it for a long period of time, have known reflux, they've done a scope, everything's okay, and your doctor recommended to continue it, that's different. But it's the patients who maybe were prescribed it once for one brief illness, and it's basically continued since then without reassessing it. Again, please do not stop it. But that's actually one where it's probably worthwhile with a conversation about, do we need it to be a long-term med? Can this be stopped? There's a lot of talks about some potential side effects from these medications. A lot of it's been overblown, to be honest. It's been linked to kidney issues and increased risk of pneumonia and C. difficile. But again, each at a very, very, very low likelihood of these adverse events. And if someone needs these medications because without it they have bad reflux or heartburn, then absolutely they need to be on it. But it's those patients who maybe were started on it, maybe wasn't reassessed, and kind of, doctor, we're all guilty of this, just kind of renewing it because the patient asks for it, but no one's really kind of paused and said, do we really need this? That's one where maybe next time you see your doctor to reassess it. Again, please do not stop it, because you may be one of those patients who actually does need it, and your doctor is intentionally prescribing this because of the concern of a bleed coming back or severe esophagitis coming back, but maybe worth a conversation. Another class of medication that I think is worth a reevaluation if you've ever been prescribed this are medications called gabapentin or Lyrica. So pregabalin is the other name for Lyrica. With kind of a move away from opiates for treatment of pain over the years, so obviously all of us are prescribing less opiates. We've seen generally, and this is really across the world, kind of an increase in prescription of gabapentin and Lyrica for treatment of pain. These medications were initially designed as anti-seizure medications, but we found that they're effective for nerve pain as well. So patients still coming to see doctors for pain don't really feel as comfortable using opiates. Often doctors wanting to help with something, and lo and behold, here's the gabapentin and Lyrica, which might help with the pain short term. The issue with these medications, both of them, is that in some patients it can cause a few side effects. Number one is weight gain in some patients. Two is swelling, so fluid retention, swelling in the legs. And number three is some issues with mental fogginess, and in some patients over time, some cognitive impairment that can develop. Again, this isn't everybody, and again, if on these medications, again, please don't stop them abruptly, because there can be a withdrawal effect from these meds if you stop them. But it's a class of medication that I think, again, warrants a conversation with your doctor about kind of what kind of pain you're in. Have the medications helped? Have we had a trial of weaning them over time? Because a lot of patients who are in pain will continue to be in pain on the gabapentin or the Lyrica, and they'll think it's helping, but we don't really know because they're in pain anyways. So it's always really important to tease out, is it necessary? Are they going to be in as much pain off of the med? And we can avoid those side effects, because if you're in a 6 out of 10 pain with it, 6 out of 10 pain without it, I'm not sure many would want to continue it. So again, I bring that up because it is a med that is becoming more commonly prescribed, not as commonly deprescribed. And I worry about more and more patients kind of getting put on it, being left on it. I've had a patients in my practice kind of with some mild cognitive impairment or some early dementia who are on these meds as well for spinal stenosis, so severe nerve pain. And we had a conversation about maybe stopping these meds to see if the cognition got better, and it did get better after stopping it. So again, not that please don't stop these meds without chatting with your doc. It definitely needs a conversation. But just if someone's been on it for a while and hasn't had that reevaluation, likely worthwhile. Been a while since I think we've talked about nicotine replacement and other means of quitting smoking. The reason I bring it up is, again, I've been in family practice now for 12 plus years. And when I started, a whole bunch of patients who hadn't quit smoking, we put a lot of patients on Champix and nicotine replacement. I got a whole bunch of patients to quit smoking. But as you get to know patients over time, once they've tried it once, I'm kind of a stale voice, and kind of a lot of them we haven't reassessed it. Interestingly enough, we've had a couple patients in the last month go on Champix, do really well on it. So I just wanted to kind of put a plug in that if you have been thinking about quitting smoking, whether or not you've tried Champix in the past, whether or not you've tried nicotine replacement in the past, always worth a chat with your family doctor. Nothing makes us more excited as family docs than when a patient comes in wanting to quit smoking, because we do have great tools to help. And the same goes with alcohol cessation too. So if you've had trouble cutting back because of either withdrawal symptoms from alcohol or cravings, or just finding that you need it to cope in a certain way with anxiety or stress or whatever, but you're willing to work with your doctor on cutting back on your alcohol consumption, again, nothing makes us kind of more excited. And again, we have great tools and great meds that do help with alcohol use disorder. So again, please reach out to your doc if that's something you're interested in. We're going to take a quick break, and we've got a few more topics to address right after this. Welcome back. Again, we're addressing a number of topics today that I've been seeing lately in family practice, in the hopes that some of it may be useful to you today. We're going to talk about there was a new osteoporosis guideline that was released late in 2023 that we haven't had a chance to talk about on the show. I just want to make sure everyone was aware of the latest guidelines there. So the guidelines have changed to anyone 70 or over should have at least one baseline bone density done. And then depending on the results of that, your doctor will guide you in terms of how frequently you need further bone densities done. If you're between 65 and 69 with one risk factor, so what are some risk factors? Risk factors: if you've had a previous fracture after the age of 40, if you've been on steroids, so prednisone, if you've had 2 or more falls in the last year, if your parent ever fractured a hip, if your BMI is less than 20, if you're a current smoker, or if you have 3 or more alcoholic drinks per day. Any of those risk factors, and if you're between 65 and 69, should have a bone density done. And finally, if you're between 50 and 64, and you have 2 or more of those risk factors that I named, then you should have a bone density done as well. And again, depending on the bone density, if you're found to be low risk, the next bone density will be 10 years after. If you're found to be moderate risk, so we have a calculator that calculates your 10-year risk. If you're between 10 and 19%, we would consider you 10 and 15% would consider you moderate risk. And then it's already 5 years or so. And if you're high risk, then we'd actually talk about treatment of osteoporosis with the appropriate meds, and you'd be having bone densities every 2 to 3 years. Okay, so just a bit of a change there. It's those risk factors. Again, we'll put them up on the screen that are important, especially for that 50 to 65, that group that gets missed. If you have multiple risk factors, to be asking your doctor about a bone density. One thing I see frequently in practice, switching gears to weight loss. So obviously, we did an episode on weight loss recently, and I know a lot of people are striving for intentional weight loss. One thing that sadly gets missed, and patients come in often too late in the process during this, is when they have unintentional weight loss. So just as an FYI, if you're losing weight and you're not sure why, I know your initial reaction may be, hey, this isn't maybe that bad, and I'm kind of happy about this. But in our world, that is generally something that needs to be investigated. So if you're losing weight more than you would, if you're losing weight and you have no idea why you're losing weight, or you're losing weight more than you think you should based on how much you're consuming, how much exercise you're exerting, you should see your doctor sooner than later. That's not something that you just kind of want to watch and wait and see if that weight loss continues. Okay. So, other symptoms, that I find kind of are overlooked in patients. Rectal bleeding is a biggie. Yes, the majority of the time when we investigate it, it ends up being hemorrhoids or a bleed higher up in the colon. That's not a malignancy. But we're seeing colorectal cancer in younger and younger individuals. And we don't want to be writing off rectal bleeding simply as, well, it's probably nothing, so I'll see if it goes away on its own. Does warrant a discussion with your doctor, who may or may not order a scope, right? They may take a watch and see approach too, depending on the story. But I don't want I don't want patients deciding that on their own necessarily. If they're having rectal bleeding, make sure you see your doctor. While we're talking about bleeding, urinary bleeding, especially as you get older. I've bladder cancer and kidney cancer can present with even one drop of blood once that goes away. Many years ago, I had a patient who had bleeding in his urine, went away. He saw me for a checkup close to a year later, mentioned it, did some imaging. By that point, the kidney cancer had become quite aggressive. So definitely nothing you want to ignore. And regardless of age, right? I've recently had a patient in his 30s diagnosed with bladder cancer, presenting with, again, just had kind of one episode of blood in the urine. Thankfully came in, got him checked out, and completely treated, completely well. So I know there are a lot of ads I've seen around bladder cancer and bladder cancer awareness, but again, even one drop of blood from the urine is never normal. If you have gone through menopause, so meaning that you have gone over a year without a period, and develop any vaginal bleeding, that is a reason to please see your doctor and get checked out. Okay, that is what we call postmenopausal bleeding, and needs an evaluation. So needs a checkup, needs imaging, likely needs a sampling of the uterine tissue. So that's, again, women who've gone over a year without a period, who had any vaginal bleeding, need to be checked out. And again, for women too, as you're approaching menopause, if bleeding is getting more frequent or heavier, again, another reason to be seeing your doctor. We've got a few minutes, so we're just gonna touch on a couple issues. Let's talk about the feet. Go from bleeding to talking about feet randomly. Toenail fungus. A lot of you have probably seen ads on TV about toenail fungus and cream that's available. So that is available for sure. But more often than not, we actually use there's pills available too that are quite effective. If they are bothering patients, I guess you use your own discretion. But what I often find is especially older men will come in after decades of this with an incredibly thickened nail, who are now asking for treatment, and by that point, it's there's virtually nothing we can do to treat it. So if there are early signs of toenail fungus, not a bad idea to get that looked at, because we do have effective treatments for it. Corns on your feet that are painful. Again, seeing either us or a podiatrist, but then getting footwear adjusted, because often these are recurrent. If someone's getting corns that are painful in their feet, warts, don't ignore on your feet. Get them checked and get them treated early before they become deeper and more difficult to treat. I've seen some gnarly warts over the years that have taken over a year to treat because they've been left for so long. So maybe jumping on that. Couple other quick things. Don't self-treat your ear infections with ear drops that you get off the shelf, because we have no idea without looking whether it's an outer ear infection or a middle ear infection, or whether there's anything else going on. So don't put any drops in your ear without direction by a doc. And lastly, trigger finger. We've been seeing a lot of. So patients have been coming in. So sometimes when you make a fist and they have trouble, like one finger will get stuck and they'll have to actually open it up. Happens as they get older. The reason that it happens is that you have tendons that go to your fingers, and the pulley that they go through will get thickened, and a nodule will kind of get caught. And treatable, there's two different ways we can treat it. Temporarily, we can do a steroid, which often gives some relief. The more definitive treatment is to see a surgeon for a trigger finger release. But again, something that you can see your doctor for, which is very treatable. So we covered a bunch of different topics. I think well over a couple dozen today. Hopefully, most of you found at least one thing useful today. And until next time, stay healthy.